Good afternoon and welcome. We're going to go ahead and get our program started this afternoon so we can move along and you won't be stuck in here all afternoon. You can enjoy the Congress and New Orleans. My name is Molly Moran and I'm a nurse practitioner at the James Cancer Hospital at The Ohio State University. Go Bucks. Yep. Okay, we can all leave now. I'm going to read some opening remarks here so we can have some just general idea of what's going to happen this afternoon. Welcome to the educational activity titled Establishing Best Practices for CML Therapy, a workshop symposium for the Advanced Practice Oncology Nurse. This educational activity is sponsored by the Institute for Medical Education and Research, or IMER as we all know it, and is supported by an independent educational grant from Bristol Myers Squibb Company. There's a sign-in sheet at the back in order to provide you with quality advanced training. We need to account for everyone in attendance, so if you haven't done so, make sure that you sign in before you head out of here. This activity is certified for nurses. Please refer to your handout materials for specific credit designations. So you are while you're enjoying a lovely lunch and a fairly entertaining afternoon of lecture about CML, you're getting credit for it. So you're learning and earning. IMER is conducting research during this activity. Your responses will allow you to meet educational needs for future activities. Practice patterns will be assessed before the activity begins. This data will reveal knowledge deficits, practice trends, and implementation of evidence-based and national guidelines and educational gaps in practice. Pre- and post-assessment questions will be presented before the educational content begins and after the key takeaways. They're designed to provide real-time measure of your gain of knowledge after participating in the activity. So sort of put a little effort into answering the questions in the beginning and the end so we can get some real information and find out, are these programs truly learning activities or just an enjoyable, delicious activity for your afternoon? Which I'm sure they're both. A certificate of completion and attendance, a program evaluation has been provided in your folder. Please complete the evaluation. Your signature is required and deliver it to the IMER staff at the conclusion of the activity to receive your certificate of completion. You'll get your CMAs upon completion. IMER has provided clinical tools and resources specific to the assessment and management of the care of the patients with CML. There's a USB jump drive, thumb drive, whatever you want to call it, that you have received. This jump drive contains all of the slides that are in the presentation today, as well as some other supportive slides. So if you feel that you're not catching the slides as we're heading through them, and note-taking is a little bit tricky to do in an event like this, don't worry, you've got all the slides on your deck on that thumb drive for to use as you need it. Also, you can go to the webpage, which is imeronline.com, for additional listings of resources in the newly diagnosed patient, clinical tools regarding staging, prognosis, assessment and management, as well as the additional patient education resources are available throughout a whole bunch of different mediums. Please turn off your cell phones during the presentation, or at least set them to vibrate, because as in my office, about 3:30 when every kid gets out of school, it's like a gigantic disco room of techno-funk. And that makes it a little tricky to work on here. So make sure you sign in. You've got the handouts in the back. Your input's very important. Let me roll along here and introduce the rest of my panel. This is the disclaimers. We've just claimed that we have no financial gains, or we're not a company. We're not attached to any of the companies. This is approved through all of the guidelines and processes for approving CMEs. Again, my name is Molly Moran. I have no apparent conflict of interest. Michael Savona, his is listed here as well, and Kathleen Curran, we're all listed on here. The learning objectives for today, we're going to evaluate the efficacy and safety profiles and second generation of TKIs, which stands for, you're in the right room. You made it this far, so you're doing great. In patients with CML, we're going to talk about primary and secondary prevention strategies for side effects. We'll talk about the management and supportive care strategies for adherence. We'll talk about health literacy and how to help patients be more compliant, culturally sensitive materials, things like that. And we'll talk about occurring CML clinical trials, what's coming, what's new, what's happening in the world of CML. Again, I said my name is Molly Moran. I'm a nurse practitioner at the James Cancer Hospital at The Ohio State University. Go Bucks. See, you always get that no matter where you go. And the president is there today, the current president. Dr. Michael Savona, here on my left, is the Director of Leukemia Research and Senior Investigator at Hematologic Malignancies and Research Drug and Development. Wow, Research at Drug and Development at the Sarah Cannon Research Institute and the Sarah Cannon Center for Blood Cancers in Nashville, Tennessee. And to his left is Kathleen Curran. Yay! Yay for Dr. Savona, yay. Tennessee, anybody? Volunteer? All right, you're representing. And Kathleen Curran is a nurse practitioner at the University of Pittsburgh Medical Center. Steelers? All right. Booyah. All right, let's learn about CML. There's the schedule. We're already screwed that up. Moving on. Okay, demographic questions. Does everybody have one of those ARS remote pusher button thingies? So we're going to learn a little bit about you guys first. All right. Which best describes your primary practice setting? Are you a community inpatient, community outpatient, academic institution, inpatient or outpatient, or private physician practice? So choose 1 through 5. Pretty evenly spread. Community inpatient. Seems to be high on the list there. Okay. The next question is, which best describes your primary nursing role? Academic educator, case manager, clinical nurse specialist, clinical trials nurse, medical science liaison, a patient navigator, patient educator, nurse practitioner, staff nurse, clinician, or other. Pick 1 through 9. Staff nurses. Majority are staff nurses. Awesome. The real worker bees. In a typical month, how many patients do you think that you see with CML? Anywhere from 1 to greater than 25, or you don't see any patients with CML? Wow, I feel good. Larry. You. A few. Good. All right, practice patterns and research. Do you have formal patient education program for CML starting oral therapy regimens within your institution? Do you have a program that is a formal, here's your booklet, sit down and read this, come to this class? Do you have a program like that? Yes, no, or uncertain? That's Larry, the sound guy. Hi, Larry. No. So it's, and a lot of oral chemotherapies are available now. And so that's important to know. Next question. Do you feel adequately prepared to provide educational information for patients receiving TKI inhibitors imatinib, nilotinib, dasatinib for CML patients. Do you feel adequately prepared to provide that education component as a nurse or other to patients with CML? Oh, well, by the time you leave here today, you just might. Interesting. Somewhat. We'll see if we can make those numbers better. Which of the following toxicities do you find most challenging when managing patients with CML? Cytopenias, diarrhea, always during lunch, sorry. Whatever, we're nurses, we can take it. EKG changes, fluid retention, headaches, leg cramps, nausea, or rashes. Which one do you find the most challenging? Not most common, but the hardest one as a nurse to sort of intervene on. The three biggies. Yeah, I would agree. I would agree. Rashes are always a bother because they come from a million different places. Okay. Which of these agents do you know the least amount of information about? Imatinib, dasatinib, nilotinib, or ponatinib? They may actually be made-up names. I'm glad you all picked number 4. It's not made up, I'm just kidding. Could be. All right. Pre-assessment questions. A couple more. Then we'll really get to the meat and potatoes here. Which of these is false? CML is characterized by a reciprocal chromosome translocation between 9 and 22, or the Philadelphia chromosome that causes a fusion of the BCR and ABL genes, forming a protein ABL, right? BCR-ABL. The Enest trial studied nilotinib versus imatinib. The Saison trial studied dasatinib versus imatinib. Dose reductions or delays are not appropriate for grade 3 neutropenia. Which one is false? I'm not telling you the answers. That's why you're here, to learn the answers, suckers. Which of the following agents possesses an inhibitory property against the SRC family kinases? Imatinib, dasatinib, nilotinib, 1 or 2, 2 and 3, 1 and 3, all of the above, not sure, quite don't know. What the heck is an SRC family? Maybe that should have been one of the answers. Haha, I still don't know. Okay, so I'm going to turn this over to Dr. Michael Savona, who is going to take us through the nuts and bolts of CML.
Okay, the nuts and bolts of CML in 20 minutes. Here we go. Well, I'd just like to thank the organizers of the event, Eimer and ONS, and really all of you. I love speaking to the ONS. I love speaking to nurses in general. You make us look good, and we appreciate it. And you're there for these patients, our patients, at really one of the most difficult times in their lives. So what you do is important, and thank you for coming here and trying to learn more on how to become a professionally farther down the road to where you are now. Hopefully I can help augment that. So CML is a unique disease insofar as that it has a dominant genetic aberration which drives the disease, and clinically I can give you this diagnosis in 95% of the patients by looking at the blood smear and the clinical presentation of the patient. On the blood smear there aren't many diseases that give you a full range of hematopoietic myeloid precursors from segmented neutrophils to bands to myelocytes to granulated pros, and increase in eos and basophils. This is a disease which is not very common. There's only about 5,000 cases a year, new cases. And that's important, and I'll get to that in a minute. Doesn't kill many people anymore, although when I started practice, most people died from this disease and not with it. The median age of diagnosis, it's a disease that people get in the mature age category, but there isn't a nurse in this room who hasn't seen a 20-year-old get this disease before. It's more common in men, and most of the time we're lucky to pick this up in chronic phase. For those of you who witnessed a patient in blast crisis, this is a condition that we can treat best by avoiding it. It's a very high mortality, and all the patients will eventually go to stem cell transplant if they make it that far, as their only chance for long-term disease-free survival at this time. So Drs. Knoll and Hungerford in Philadelphia. So if anyone asks, this is where this comes from, because it seems like when I ask nurses this, nobody really knows where Philadelphia comes from. Drs. Knoll and Hungerford in Philadelphia noticed that all their chronic granulocytic leukemia patients, that was the old name for CML, chronic granulocytic leukemia, they all had on the classic karyotype, when they did metaphase spread and looked at the chromosomes, they all had a piece of their 9th chromosome and their piece of their 22nd chromosome put together. Over the next 2 decades, it was determined that the break point between those genes was, or between those 2 chromosomes, was at the Abelson kinase gene and the breakpoint cluster region on chromosome 22. I explained to patients that bcr-abl, Abelson kinase is like an oil derrick on the surface of the cell. And then when that oil derrick is pumping, that cell is proliferative and moving to grow. Normally, that oil derrick turns on and turns off when the organism, the patient, signals, has some kind of stimuli that influences cell growth. There's an infection, you need more white cells. In this disease, that oil derrick is always running. It's constitutively active. Increases proliferation. The life-death homeostasis is in favor of living long, and it shuts off apoptosis mechanisms. And it modifies differentiation, so you get cells seen early and earlier. And this is why you see cells on the smear that shouldn't be on the smear, that should be in the bone marrow. Interestingly enough, about a fourth to a fifth of the patients who have ALL on presentation have the presence of the Philadelphia chromosome. And this is, tyrosine kinase inhibitors have changed the treatment of this disease as well. So in CML, this is a hematopoietic stem cell disease. The genetic malformation is present in the hematopoietic stem cell, but the problem is when that genetic aberration is passed through hematopoietic ontogeny, first to the progenitors, and ultimately downstream to the myeloid cells here, increased platelets. What happens in CML, in the wheat cell, where that bcr-abl is present, there's not much change. But as this replicative index is increased downstream, ultimately you get more and more of the chaff, the end product. And imatinib and the other tyrosine kinases work on the chaff, and we're going to talk about that. In chronic phase, you see, this is kind of a misprint. This should be really 2 to 15% blast. You may not see 10% at all. In this disease, in natural history, it should last 3 to 5 years before patients die of it, and this gives us some time. In a more advanced disease, there's more blasts, greater basophilia, and untreated, these patients are dead in anywhere from a median of 6 to 9 months. And of course, in blast crisis, there's more attribution of genetic aberrations at the progenitor level, and these patients untreated have a median survival of 3 months. So like I said, the best treatment for these folks is to avoid this condition in the first place. So this is kind of a busy slide with a lot of information, and you can spend time looking at this on your thumb drive and your printout later, but it captivates a lot of the concepts that I'm going to be talking about and that you need to think about when you think about CML. We like to think that, and notice time, there's no units here, right? So we don't know exactly what these time units are, but know that if we catch CML early in chronic phase, there's not a lot of genetic instability. The disease is addicted. Bernie Weinstein in the mid-90s kind of hallmarked that phrase, and it's been very important in the description of bcr-abl's role in CML and other cancers. But Early in CML, the disease is addicted to bcr-abl. If you take bcr-abl away, the disease goes away. Over time, that increased lupricative index, those cells want to survive, and they have more and more genetic aberrations. At some point, and I've called it the anaplastic threshold for lack of a better term, and notice it's fuzzy because we don't know exactly when that is. We know the phenotype is accelerated or blast crisis, right? Accelerated phase of blast crisis disease. But at some point, the disease no longer relies on bcr-abl alone. There's other genetic mutations that drive the disease even in the absence of bcr-abl, which explains precisely why you see patients who get TKIs who continue to progress, right? You shut down the bcr-abl, but they still have the disease. So how do you shut down the bcr-abl and take care of those chaff cells? Well, imatinib was the first drug that addressed this precisely. Imatinib is a small molecule inhibitor of bcr-abl, which was designed to fit in the inactive conformation of the ATP binding site for this oil derrick, if you will, on the surface of the cells. It's a little promiscuous. Oops. It's a little promiscuous. It binds with ABL, it binds with ARG, it binds with KIT, it binds with PDGFR alpha and beta. I don't know if that's an accident or not because the makers of these drugs have found other places to use them, and now this is a billion-dollar drug. So I guess if you had one target, that might be the only place you could use it. Now, I can give you a similar graph from U.S. treated patients, but the Swedes did it first in ASH. It gave the first 10-year summary retrospective analysis of how patients did over the years with change in treatment. I feel like this is fairly instructive, so I'd like to just go over it briefly. Back in the day when it was just chemotherapy for CML, the median survival here, we're talking about 2 years. In the advent of allogeneic stem cell transplant, in here, between these two lines somewhere, these lines flatten out, and there were long-term survivors. In the advent of interferon alpha, there were patients who had long-term disease-free survival, but if any of you have treated patients with interferon alpha for CML, they don't like it. They've got a flu for a year. I had a patient jump out a 4-story window. There's a lot of depression, suicidal ideation. This is a drug that we only use when we have to use. It's not something that should be taken lightly. This is in the imatinib era. And if we look, this is 2001 to 2010, and if you look beyond 2010 and going forward, I would reckon that line's going to be quite a bit higher. Because in 2001, not everybody had access to imatinib who had CML, and that included patients who were farther along in the disease when the drug became available. Well, what happens when imatinib doesn't work? There's lots of reasons imatinib stops to work. And in the confines of this talk, I've talked for an hour on just secondary resistance to imatinib and the generation of tyrosine kinase inhibitors, but for the sake of this discussion, it's real simple. There's bcr-abl dependent resistance mechanisms, there's overproduction of bcr-abl, and there's bcr-abl independent mechanisms. bcr-abl dependent mechanisms are mutations within the bcr-abl kinase, and I'll show you specifically how that works in a second. If it's not in the actual kinase, and not a mutation in the actual oil derrick itself that prohibits imatinib from fitting in there, maybe the cell just decides in trying to survive to make more and more bcr-abl where you just can't give enough imatinib without causing dose-limiting toxicity, right? That happens sometimes. We usually see that in later phase disease. In BCR-independent mechanisms, and frankly this is largely uncharacterized, but we know that the hematopoietic stem cell has definitely used some of the built-in hematopoietic stem cell robustness and used these mechanisms to keep imatinib out of the cell. You know, upregulation of drug transporters, things like that. SARC activation, we think, is part of it. I won't go into it here, but just know that it's not always bcr-abl dependent mechanisms. So if you look at a structural model, you know, these ribbons, it's thousands of atoms and amino acids here, but just know that the depiction, and I wish I had a better 3D picture for you, and I apologize that I don't, but just know that the picture is of the bcr-abl molecule, and the yellow is the drug. And just, you know, the drug can get in there real nice. And sometimes there's an amino acid switch where there's a big fat amino acid that just doesn't allow it to get in there. So those are mutations that are directly affect the binding of imatinib. Sometimes there's no mutation right in the binding site, but there's a mutation somewhere else in the ribbon that changes the conformation of the whole molecule, so there no longer is a nice docking site. Think New Orleans post-Katrina. Now, some of these mutations, it doesn't matter. Imatinib still works. You can see WTP210 is wild-type bcr-abl, so that's like the non-mutated form, and you can see with increasing doses of imatinib, that bcr-abl goes away. You can also see with the M351T, it goes away with increasing doses. Unfortunately, as you go up in color there, all the way to T315I, you have mutations that fail to respond to imatinib. And those are mutations that are sensitive to second-generation tyrosine kinase inhibitors, with the exception of the one on top, that T315I, which is only sensitive to ponatinib, which is now a fourth-generation drug in clinical trials. Some of us, including myself at Sarah Cannon Center for Blood Cancers, have this drug available on expanded access. I believe they'll have it at Ohio State. I don't know if they do yet. But there's several academic centers, so if you have a patient who does have T315I, remember there are places that have this drug as it's going through the FDA approval process, that if you can't get it, we might have it at our center for your patient. Trying to get those T315I patients to transplant is tough when they still got active disease, right? So ponatinib's a chance to turn that down. Let's talk about the drugs that are on the shelf. Nilotinib is an imatinib analog. I like to think of a nilotinib as a stronger, smarter, less toxic imatinib. This drug also inhibits the PDGFR alpha, only it's less strong in that moiety. It's 20 times more potent with regard to the bcr-abl, at the bcr-abl gene than imatinib. And it inhibits most of the bcr-abl mutants to imatinib, with the exception of the T315I. I'm going to breeze through that. Dasatinib is a different kind of drug. Dasatinib has got a different structural composition, and it also inhibits the Src family kinases. And you remember that slide where I showed bcr-abl independent mechanisms, and Src activation was part of it? Well, we think that Src activation or inhibition of Src activation may actually help in these more advanced phase disease, and that's why dasatinib may have an advantage there. Of course, when you have an expanding dendrogram, the concern is toxicity. Now let me explain that statement. I'm sorry about how this came out, by the way. This is not my doing. It's some kind of computer glitch that happened without my understanding of how that happens. But the yellow, it's supposed to look a little bit more like a starburst, not disconnected. But the yellow are the genes that are affected by the drug. And you can see nilotinib and imatinib have similar genes affected on the dendrogram. But dasatinib, in addition to those genes, also has these Src family kinases on the side. Dendrograms are kind of helpful graphical representation when you want to see just how promiscuous this drug is. So with promiscuity comes potential benefit, but comes potential toxicity. And that's what both of these companies that have these later generation drugs are dealing with now. The most important thing since the IRIS trial that got imatinib its liftoff to happen in CML were these two papers published in New England Journal of Medicine in the summer of 2010 by some of my friends and colleagues. Nilotinib versus imatinib and dasatinib versus imatinib. And I'm just going to kind of go over both those trials. And SND is the nilotinib trial. And it's not really important to know that about the 400 milligram dose. Just know that because the 400 milligram and the 300 milligram dose were the same efficacy but more toxicity in the 400 milligram dose, the important take-home point is that the patients who got nilotinib got deeper responses faster. Now, the survival is no different because the survival is so good it's hard to statistically tell a difference, right? But what we do know is that deeper remissions are correlated with increased survival. We know that from years of writing papers about CML since the discovery of bcr-abl. Likewise, the decision trial, done a little bit differently, but they looked at complete cytogenetic remission as their primary endpoint. But when you look at the rates of major molecular remission, you can see that at 12 months, they had superior major molecular remission, and that maintained on follow-up data. I don't want to spend a lot of time because I'm already down to 3 minutes here, talking about what are the expected benchmarks. That stuff is published at the NCCN guidelines and at ELN Leukemia Net. I can talk about this in the question and answer session in more detail, but it's very important that a lot of thought went into these guidelines, and it's very important we try to adhere to them to some degree. Okay, so here's the hottest thing since the New England Journal papers in 2010. And I don't want it to show this data to influence practice. I want to show it to you to influence how we think about CML. David Marin and the folks at Hammersmith look at patients who were treated over 8 years, and turns out that I'm just going to go straight to this slide. Turns out that patients who had less than a 10% transcript or less than 10% of their bcr-abl to abl at 3 months had an increased survival, and the survival difference was statistically significant and not subtle. So, mind you, this is retrospective data, but the patients who don't reach a molecular remission quick, at 3 months even, those patients are just destined not to do as well. So now, this is getting us thinking, what is the place for imatinib? Well, if patients who are on imatinib take imatinib and they get a deep response at 3 months, there's no evidence that drug, as long as they tolerate it, isn't as good as the other drugs. This does, however, get us to wonder about what we should do with those patients who are on a first-line drug who don't meet their molecular benchmark at 3 months. And now there are prospective trials which we're participating in, and over the next few years we're going to learn what happens if you prospectively attack this to survival. Will we be able to show a survival benefit? I've put in several slides which I don't want to discuss in the interest of time, and this is going to be a point of much of our discussion later, so I won't belabor it. But nowadays, you can use any of these agents for CML up front, and you can be justified in any one of them. You know, I had a mentor tell me once, don't be the first on the ship or the last one off of it. And so when dasatinib and nilotinib first came out, everybody started prescribing these drugs, and there was very little clinical safety data with these drugs. Now we're getting more and more safety data. It's more and more acceptable to start those people on those drugs up front. The trial that I just mentioned is an attempt to try to be a better steward. And when you've got a drug that costs $50,000 to $80,000 a year per patient, we have to be better stewards. So I'm going to zing through these, and I want you to look at them later. I've even put a slide in about bosutinib, which is a third-generation tyrosine kinase inhibitor. And you can look at the adverse events from the trials to figure, you know, if I got a patient who comes in who has heart failure and trouble with lots of fluid retention, maybe imatinib is not the best drug for them. I got a patient with SLE, with lupus, who has pleurisy. Maybe that's not a good patient to give dasatinib to, because if they get pleural effusions with dasatinib, that might put us behind the 8 ball. I got a patient who's an alcoholic who has chronic pancreatitis. Nilotinib and ponatinib are not the drugs for that patient, right? So sometimes the patients help make decisions for us. This slide, I think, is probably one of the more important take-home slides I want to show you. The disease happens, the incidence of the disease is about 5,000 patients a year. We're keeping these patients alive, though, which is great. But from a medical pharmacoeconomic standpoint, this means by the year 2030, if we don't change anything, we're going to have 120,000 people on a medicine that costs $50,000, $80,000 a year. So we have to do better. And we are. We're making attempts to be good stewards with the use of these drugs. We're also looking at different pathways to attack this mechanism, to attack bcr-abl, to get people off the drugs so they don't have to take a pill the rest of their life, but we can attack that wheat cell at the top of that hierarchy and get rid of the rogue hematopoietic stem cell and the tyrosine kinase from the get-go. I'm a stem cell biologist, so I'll just end on this little encouraging insight that we've gained about stem cell pathways. You know, the ideal stem cell pathways that you want to, or druggable stem cell pathways, are those that you need in embryology to become an adult. They're quiescent in the adult cell in order for homeostasis to live, but then cancer hijacks them. So if you can find a way to just get rid of those, Can you get rid of it in the stem cell? And that's being explored through the hedgehog pathway, the Wnt pathway, and the Notch pathway. And there's lots of preclinical data to show that this is definitely a good direction to go. And I'll just give you this gives a chill down my spine. And we're using this drug now in our facility, and the first phase 1 in all heme malignancies. And I'm not going to explain the sonic hedgehog gradient, but just know this is a hedgehog inhibitor, right? Very well tolerated drug. In the 7 cases of people who had acute leukemia, in the 20 cases of people who had acute leukemia, nearly half of the patients had a reduction in blasts of greater than 50% with this drug up front. Single agent, multi-drug refractory AML. So I think there's a lot of promise moving forward with attacking the stem cell pathways, and if we can find a way to use those with cytotoxics, or in the case of CML, with tyrosine kinase inhibitors, I think we're going to have some success. So the key takeaways, are know that CML is hallmarked by this 922 translocation. Know that we have lots of choices, and none of them right now, at least the ones on the shelf, are the wrong choice, but we need to be good stewards of how we use them, and we need to be informed. I didn't spend a lot of time because I'm already at 22 minutes, and this is my life's work, so it's hard for me to put it in 20 minutes. But I'll tell you, one of the things that, as a physician, that I think nurse practitioners and oncology nurse specialists can help with these patients is we have to follow these benchmarks more closely. We have to look more closely in the bone marrows, and we can't be so cavalier about not doing bone marrows. We're leukemia doctors, and the bone marrow it's our microscope. That's how we get in there and see what's going on with the disease. And the younger oncologists who have come along since TKIs have been out haven't seen patients die in a nasty death of CML. And they become cavalier, and I have referral after referral of patients who have molecular monitoring only for 18 months, 2 years, and they never see the clonal evolution that's happening in their bone marrow, and they come to me with blast crisis. So if you can find a way to get those guidelines and remind your physicians, you're doing a great service to the patient. Thanks for your attention. I appreciate it.
Thanks. Terrific. Thank you so much. I think it's kind of neat how you and I sort of fall in the same era of starting in this whole journey, in that we have, what are we talking about today? 4 drugs solidly, 6 drugs for the treatment of CML, and 10, 15 years ago we had 2. And stem cell transplant, none of which were pleasant options. And so it's kind of neat to be part of this evolution in the treatment and turning diseases that were lethal into a more chronic state. So that's kind of cool. Thank you. We'll have, you can write questions there's cards on your table if you have questions that you want to have asked. And if we don't get to them, we'll get to them, post hoc and after follow-up. But we'll try to answer any questions that you have at that time. So now we're going to go on to the roundtable workshop, which means audience participation. Woo! Come on, it'll be fun. I promise. You'll have on your table something that looks like this, a purple sheet. There's 1 per table. And I'll explain more about that. So see if you can kind of find that little thingy on your table. And we'll talk more about what that's going to be. Okay. Here we go. We're going to go over a case study, and then you guys are going to talk amongst yourselves about the case study and treatments. Our case study involves which you probably can't read this from where you are in the back because the writing is very small, but it's the same information that's provided on the purple sheet. I think there's, I don't know how many are on each table. I don't think there's a bunch. I think there's a couple. A 48-year-old flight attendant presents for her annual physical exam. She's in her usual state of health and is without complaints, but on exam she has a spleen that's palpable at 5 centimeters below the left costal margin. On further looking, she has a white blood cell count of 38,000, some basophils, some eosinophils, and some blasts in the peripheral blood. Her platelets, 550,000, which is high or low. Very good. Okay, you're still with me. LDH 250, slightly above normal. Uric acid 7.8 in a range of 4 to 6 or 4 to 7, 6, something like that. And the remainder of her labs are normal. Her liver functions fine. Everything else looks good. Creatinine clearance is good. Physical exam was otherwise normal with the exception of this palpable spleen. Her medical history includes type 2 diabetes that's treated with metformin, and hypertension, which is controlled with lisinopril and hydrochlorothiazide. Sounds like someone's been in my medicine cabinet. I know. Family history is negative for leukemia or lymphoma. She has 2 brothers and a sister that are all well and healthy. CML is suspected. She has a bone marrow biopsy. Very important, as we just learned, that it's important that you do the bone marrow biopsies and not try to do all this from the peripheral. Although the peripheral blood testing is sensitive, you still need to look in the manufacturing center. Confirms the diagnosis of CML with 8% blasts, 2% basophils. Cytogenetics are 46XX with translocation of 9 and 22 in 20 out of 20 cells. She's FISH positive in 98% of the cells for bcr-abl metaphases. bcr-abl fusion transcription is positive by RT-PCR, real-time polymerase chain reaction, right? RT-PCR. Sound familiar? Some of these when I was going over my slide deck last night, I realized that you could give this whole talk without actually saying a single word in English and just use abbreviations. You could truly get through the whole thing and never actually utter a word of English. Crazy. Confirmed CML. So this is we're just going to skim through some of this so we can move on, and then you guys can talk amongst yourselves. Things that you do in a workup, nothing replaces a physical exam ever. You always have to lay your hands on a patient. You always have to eyeball a patient. A performance status is important to be seen. You may see something on paper. We all know terrific 92-year-olds, and we all know terrible 41-year-olds. And so placing that all together, doing a physical exam, laying your hands on them, you can't replace it. General lab work, looking at the kidneys, liver, baseline hepatic, lipase, amylase, you got to look at for early signs of pancreatitis. Some of the drugs interfere with that. You want to do HLA typing, possibly getting ducks in a row for that, rare occasional bone marrow transplant resistant patient. Still a cure, still an effective cure, right? I'm deferring to Sir Transplanter. Caught you off guard, sorry. Oh, goodness.
I think that's another, am I on? I think that's another point to remember is that we have new drugs, but stem cell transplant, allogeneic stem cell transplant is still part of the game. And this is a debate we have. If you pick up your, community oncology news, and there's a debate on the cover, and Sergio Giralt, who's a pro-transplanter, is debating for taking people to allogeneic stem cell transplant after failing one of their TKIs. And then Jorge Cortez from MD Anderson is a pro-drug development non-transplanter who's arguing to make sure they fail all their TKIs before going to transplant. Mm-hmm. There's not a right answer there. You have to kind of put the individual patient's situation in context.
Yeah, exactly. And this is an ongoing debate that will, I doubt, ever be 100% resolved. You do bone marrow aspirate and biopsy, again, very important. Cytogenetics, FISH analysis. The most important thing when you're talking about these, I'll call them high-tech laboratory analyses, things like FISH and RT-PCR, it's most important that the lab stays consistent and that you try to maintain using the same lab throughout. So if you have a patient who comes from a distance and says, I really don't want to come back every 3 months to have my blood work checked, you really sort of have to encourage them that it's important that these are maintained in some of the same laboratories so that you get consistency across the board. Yeah, Mike?
So, Molly, I think that's a very important point, and I just like to underscore that, when you read these clinical trials and look at benchmarks for molecular response, you're looking at a centralized lab that's looking at international standardized scale bcr-abl to abl ratio. You may not use that in your lab. Labs across the country are trying to all standardize this now. We at Sarah Cannon have been kind of perfecting that over the year, and we'll be starting our new trial, or our new assay in the next month. But that's very, very important. The other thing that's important is that I don't know if everybody in the room understands the difference between a metaphase spread and an interphase FISH. And a metaphase spread is when you arrest the cells in division. You encourage them to divide in a petri dish, and you arrest them in division. You look at the chromosomes under a microscope, and they look like the X's, right? And you count the chromosomes, and you see if there's too many. You see if the 9 and 22 are together. My eyes and your eyes might not be able to see it, but a trained cytogeneticist can tell when there's minute differences that are foreseeable on the microscopic level. Now, on the molecular level, you can't see that, and that's where FISH comes into play. FISH, instead of looking at 20 cells in arrest on a metaphase spread, looks at 200 to 400 cells at a time, so more sensitive. But what it does is it hybridizes a fluorescent antibody to that breakpoint. So if you have a red for BCR and you have a green for ABL, you should, in normal situations, see them apart from one another. And if you see those together on a few cells, and you have the presence of the bcr-abl. What's the problem there? Is you can only see what fluoresces. So you don't get to see all the other genetic changes that you see on a classic karyotype, which is why it's so important to do classic karyotype at 6 months and a year in these patients, because if the disease is more advanced and they develop clonal evolution, you won't see it with a FISH or molecular testing.
Mm-hmm. Thanks. Is that helpful? Yes, absolutely. These are the parameters. We talk about chronic phase, blast phase, and accelerated phase based on the number of blasts in the bone marrow. And blasts, in low number of blasts, considered chronic phase, high number of blasts, considered blast phase. And the survival is very different for patients who are diagnosed in chronic phase versus blast phase. I always struggle with accelerated phase because to me accelerated implies 2 points in time. And so if you're only getting 1 point in time, it's hard to look at accelerated, but you're heading on to blast. This looks at survival. This is in the past. We talked about the change in survival and the prevalence of CML. Currently, patients who are diagnosed in chronic phase have the potential to live greater than 25 years. Accelerated phase and blastic phase, much less likely to have a long-term survival, although improving certainly as we get more options. This is that same sort of idea of looking at past versus present. It's the same data that you were given before. The less steep the line, the more people are alive. And this is in the newer days with tyrosine kinase, the outcome is significantly different. We're going to learn to calculate Sokal and Hasford scores here. No, we're not. I'm just kidding. Because you can plug it in online and it'll tell you what your Sokal and or Hasford schedule. So anyway, get out a pencil. Anybody? No? Take the square root of... I am my best audience. I truly am. And Keith knows that because I'm running behind here. Anyway, Sokal and Hasford scores. Thank you. All right. Okay, she's got CML. She's got one of the following options for treatment. Imatinib, 400 daily. Imatinib, 800 daily. Dasatinib, 100 daily. Nilotinib, 300 twice a day. So now, in your little group there, talk amongst yourselves about, it should say which therapy your table is giving on that purple sheet. And they're off. As you're discussing amongst your group, try to pay attention to things like disease characteristics, lab values, cytogenetics, treatment selection rationale, the definitions of monitoring, adverse events, dose adjustments, monitoring of response. Certainly Anything else you want to talk about? This is going to get tricky.
So we talked about this in this is we talked about this in
I think so. No, we talked about it now.
now.
Some. This is what they just handed me. 5 minutes to discuss, 5 minutes to recap, and then Kathy. So you go on in 10, kid. If you have any questions or come up with some points at your table, discussion points, if you write them on a card, raise your hand. One of the moderators will come and get them. Yeah. That'd be fun. Larry, turn.
Oh, wait, what?
Yeah.
You've got about another minute and a half to... I see ya. I'll come and get him. Keith's coming from behind you. So you've got about a minute and a half to sort of wrap it up. Thank you, sir. So if you want to start to wrap up your discussions here, and we'll go ahead and cover some more ground in CML. Alrighty then, let's bring it on around. They're all for you. Okay, so you got to discuss at your table the options for frontline therapies in CML. We're going to just sort of zip through some of the coverage. Again, you'll have all of these slides, and you'll be able to go sort of back through them and read and decide. So we'll talk quick. The Irish trial, which was the biggest data collection, the first trial that looked at Gleevec versus, or imatinib versus interferon, and got its approval. Looking at the, again, early survival. Some of the take-home magic of all of this CML stuff is early detection of resistance, and early response rates means better survival. You get more for your buck out of the first bang of chemotherapy, and that's absolutely true in all cancers, all chemotherapies, all treatments. You want to get your best bang for your buck right up front. And so monitoring these people closely, these patients, sound like my father, these patients. He was a high school principal, and he always referred to kids as these people. Or you people, sit down and shut up. He was, anyway. So monitoring early, looking for responses early, changing gears, changing therapies, intensifying the therapy, monitoring the side effects, evaluating the tolerance, who's sticking to the regimen, which Kathy's going to address shortly here. 3 months, 6 months, 12 months, 18 months, and then it becomes sort of a yearly thing once you get beyond the first year and a half. But you need to look for these magic milestones. Not magic, we know what it is now, it's science, but you need to look for these milestones. Clearance of your bcr-abl, whether it's through FISH or RT-PCR, and watch for those early trends. Again, looking at the time to how long initial therapy works, it works right out of the gate. Within the first 3 months is when you saw the best responses. Over time, people can develop resistance and develop drug resistance. Dasatinib was the next. I always look at these, you call them derivatives or analogs of, I call them the son of imatinib.
Oh yeah, well, so I don't know if anyone knows Moshe Talpaz, who is probably, he's been through this whole thing, and Moshe is Israeli, and he's a big man, and he always says, the sons of Gleevec, the sons of Gleevec, and soon we have the sons of dasatinib.
I always refer to them as the sons of Gleevec.
That's
so.
right. Yeah.
But they do have more respect than that now in the community. Dasatinib versus imatinib. Are you seeing a pattern in the names here? Yeah, that tinib? Huh? Nothing gets by you guys. Tyrosine inhibitor? Yep, okay. Just checking. Again, looking at response rates. There was nilotinib versus imatinib, newly diagnosed chronic phase. Big groups of patients. Looking at response rates, looking at tolerance, looking at clearance, how long does it take to clear? There are mechanisms of resistance. Again, looking at the full cytogenetics, looking at FISH and the breakpoints, looking at all of this together helps to help choose that pathway for treatment, SRC activation, and certainly resistance there. You want to look at newly diagnosed versus resistant. The therapies change. Same data again. Toxicity profiles, you're all pretty familiar with those kind of things. Imatinib, dasatinib, and nilotinib. They all have some hematologic toxicities in the beginning. You press through, try to get them on treatment. Some GI toxicities. Imatinib, amylase, and lipase are elevated. Dasatinib tends to have pleural effusion complications, fluid retention, and anemia in nilotinib. Again, knowing how to treat all those. So myelosuppression, these will all be available for your management. QTC reactions, if you look at the list of drugs that interact and cause QTC elongation, it's hard to think that they could be on any other medication other than a TKI. So you really have to be cognizant of those things, make sure that their electrolytes are intact. General patient education, don't crush the tablets, all these kind of things. No grapefruit juice. That one bothers me. I know. I know. My father thinks that if he drinks grapefruit juice once in a year, it'll eliminate all of the efficacy of all of his medications for the entire year. Like it's his kryptonite. We have a couple of quick questions here that we're going to review, if you wouldn't mind. Dr. Mike?
Sure. So I'll answer this one first. So some folks from MD Anderson had asked, and I don't know if Mary Beth Rios is here, but say hi to her if you're here, and she's not. Yes, Gleevec is the original TKI, and nilotinib and dasatinib are both second-generation tyrosine kinase inhibitors. I wouldn't like you to walk away from this thinking dasatinib is a generation after nilotinib. They came out around the same time. They're just different insofar as that the same company that makes imatinib makes nilotinib, and it's an analog of imatinib, and dasatinib is not really an analog of imatinib. It's a different drug. As far as they also ask about being treated for other diseases with TKIs. That's being explored. There are clinical trials. If you go to clinicaltrials.gov and put in the search box dasatinib, I guarantee you'll see more trials for non-hematologic disorders than you will see hematologic disorders. Just like I told you, that promiscuous dendrogram has lots of genes that are involved that we're not sure how they work. It's always scary when we get response. We have no idea how it's working, right? But sometimes people, as we know, with late-stage, solid tumors, they don't have other options. And we've had people get response with dasatinib with the various different solid tumors in clinical trials, so we'll see how that goes forward. The science behind that I don't want to get into. I will say that the PDGFR alpha and beta inhibition and GIST tumor, I've seen tremendous response in that, and that's being used by the people who take care of GI oncology quite frequently. I'll save the hardest for last.
Okay. I have a quick one for you. How often is a bone marrow biopsy done post-diagnosis and then once they're stabilized?
So the answer is it depends, your favorite answer. So the NCCN guidelines, and I agree with this, will tell you to do a bone marrow biopsy at diagnosis, at 6 months, at 12 months, at 18 months, and 2 years. There are extenuating circumstances which may lead you to do biopsies more frequently. There are patients who will negotiate you down to doing it once a year. And you have to work with reality, right? But the patients who show evidence of genetic evolution, clonal evolution at diagnosis, those patients should not go 6 months to a bone marrow biopsy.
Very good.
These are a lot to get through. I don't know how many you want to go through here.
We can save those and we'll do them at the end of once Kathy gets through her program.
Yeah, we don't.
And then we'll touch base on those kind of things. 2 more bits of housekeeping before we move on to Kathy's presentation. The case study purple sheet, if you can leave that on the table, we want to use that to collect some data. So leave that here for us so we can look through that. Even if you wrote bad things on it.
Unless you wrote bad things about me, in which case you can take it.
Take it away. Shred it. If you drew pictures on it and said how stupid this was, we'll know which table it came from because they're all marked. They're not. The second part of housekeeping before we get on to Kathy's presentation here is that as you're leaving, you'll be asked, you'll get your certificate, but before you're handed your certificate, you'll be asked to spell Tchoupitoulas. If you can't spell Tchoupitoulas, you ain't getting out of here. Just checking. And you locals, no cheating. So Kathy's going to talk us through medication adherence, patient care, and caregiver teaching.
Thank you. Thanks. And I guess you were probably wondering what I was doing here. So as a nurse practitioner, I'm the one that gets the phone calls. I see the patient first before they go on to the physician. And I'm responsible for doing a lot of the teaching. So, this is an ARS question. If you take your little tool that you have on the purple string, and this one, I'd like to know about you. So, do you always take your medicines all the time, exactly as they're prescribed, every single day, every single time? Or maybe if you're a kind of person, if a medicine's prescribed for you, you take it most of the time, but, you might miss a little bit. Or maybe, it's so expensive, medicine's so expensive. If I'm really, really sick, I might get that script filled. Or this medicine makes me feel bad. I'm not going to take a medicine that makes me feel bad. Is that you? We're talking about you. Lastly, my doctor, my nurse practitioner, they yell at me and they make my life miserable. So I just don't tell them all the truth all the time. Which one is the best fit for you? Well, I might miss a dose or two, but I do what I'm told to do. I understand. And that's what most of us said, and that's pretty good. That's pretty much the national average as well. One of my ARS is gone. Nevertheless, so medications and compliance. We have excellent medications for this leukemia. This is called the good leukemia. It's the one that you can survive, but medications don't work in people who don't take them. You have an illness, you have the medicine, I have to take it. Most people with chronic disease take their medication about half of the time, about 50% of the time. We know that these medications are really very smart. They're going to treat the disease, but administration has to be done for a long, long time. So the patient may be very eager to stay on track and fill their medications and take their medications at first, but then they might have side effects and they might change. Patients might think, oh, it's okay to stop taking my drug. In fact, last month they told me to not take my drug because I had a rash and they wanted to see what was going to happen. So sometimes people think that a drug holiday is okay, and it's actually not. Skipping doses is not okay with CML. About 25% of patients who have CML don't take their medication as directed. And this information, guys, comes from the trials. And if you've ever had anybody on a clinical trial, you know that it's very, very regulated. You have a lot of folks that are involved. They are getting data from you, what time. You may even the patients may be getting their drugs from the clinical trial. So the fact that 25% don't take it as prescribed, that's on clinical trial. That's the honest number. Unfortunately, that's not good enough. We kind of are in a culture where, oh, that was really good. Everybody gets a trophy because you tried, right? That doesn't work with leukemia. Patients who were not able to be compliant or adherent is the new buzzword, actually never went into complete remission. Not one person who took less than 80% had a complete response. That's important data. So why don't they take their medicines? We have seen that thank goodness we have a treatment. Why don't they take their medicines? How many people think it's because of the side effects and you're going to be using your ARS? Is the medication too expensive? Is that why people can't afford these kind of medications? $50,000 a year? I don't have that much money. Do they not believe that they need the medicine? Sometimes people don't believe it. That they have a serious disease because maybe they don't trust their practitioners or maybe they're not a trusting person. How about forget? Do most people forget? Or how many people think it's a combination of all of the above? Could you answer, please?
Look.
Well, it's a little bit of everything, isn't it? Many reasons as snowflakes. Yes. There is not one reason for even one individual. You will talk to these folks and you'll find a lot of different reasons, and sometimes you'll find no reason. The research tells us most people don't take their medication because they forget. Other people don't take it because they don't trust the medication and the medication makes them feel bad. I would like you to think about your patients that are on any of these TKIs and watch them and try to figure out who do you think is going to be the most adherent. Because we know that in order to be adherent, they have to make sure that they take their drug every day as directed. Are the regimens too complicated? Does it make them feel bad? You have to interview all of your patients privately, independently, and you can have a gentleman with CML and you can interview, spend a half an hour talking to him, enjoy yourself, find out a lot about what's going on at home, but then you find out that, I don't take, my wife gives them to me. So that's really the person that you should have been speaking to. Try to find out what's going on in that situation, in that home, about medication. Who is the leader in that family for medication? It may be that the wife gives the guy the pills, and the pills sit there all day, and the wife says, well, if he doesn't want them, that's fine with me. Or maybe it's the wife who's giving him and gives that medication and says, oh man, he's so mean when I give him that medication, I'm not going to give him that medicine anymore. There are a lot of reasons, but it takes a lot. There's not one good reason. There's a lot of reasons for every person, every single person that is trying to take a medication. A lot of this research comes from hypertension. A lot of this research comes from diabetes and also in some of the mental illnesses. Because we know that those three diseases are very, very chronic. People can do better, but people don't. Why don't people listen to us? So what works? Okay. You identify patients that are at high risk. People who miss their appointments. People who you know that they're not taking their other medications. People that you just have a sense down in your soul, they're not telling me the truth. And I don't know why. And they aren't telling you the truth. You discuss how they feel about their need for treatment. Some people don't believe that they really need treatment. CML, like our flight attendant, she's asymptomatic. It was her regular physical. Oh my God, I have leukemia? Oh, thank God, it's a good one. So you have to evaluate all of your patients. What do they do for a living? Who gives them their medication? What other medications are they taking? And you try to make it as simple as possible. They found, through a lot of research, because a lot of chemotherapy is becoming more, pills and oral formulation rather than IV formulation, so there's a lot of push in this regions. You have to look at every single medication that's been prescribed. You have to make it as easy for them as possible. A calendar is a good idea for some people, where you give them a calendar, they put it on the refrigerator, you ask them to bring it in. For some people, you're going to give them the calendar, they're going to walk out of your office, the calendar's sitting right there. So you're going to have to do something else for that person. But it's a very individualized approach. Every single person has a different reason for not taking their medication. You try to do a lot of listening to that person. You listen to the patient, you listen to the family. Sometimes the patient will tell you, yes, I've taken all of my medication. Well, and then you have 5 minutes with the husband. She's not taking that medication. I haven't filled that medication for her for 3 months. So you have to listen to the patient, the family, and then you also have to listen to the pharmacist, to the other nurses that often know way more about the patient than. It's scary sometimes how the other nurse sometimes know the names of the cat, the name of the dog, where they go to get their medications filled, where they were last week. So you have to listen to them and try to formulate for that individual person a plan that's going to work. So one of the things that I mandate is that everybody brings all their medications. Now, remember, to every visit. Older people don't think it's a medication unless a doctor prescribed it. So you have to make sure that they're also bringing in all their over-the-counter medications, all the herbal supplements their daughters and sons are having them take. But bring everything. And that will bring, you'll be able to at least look and you'll say, well, when was the last time you took this? oh, I just take that if I have a migraine. But it's there in your box and you know about it. Sometimes, right at the beginning, you might want to call that patient very frequently. How are you feeling? What are you experiencing? You might give them a diary and then have them go get their diary, and you call them at an appointed time. Some folks you're going to have to call the pharmacy as well. So this is information you have to get at the beginning. These drugs come through a specialty pharmacy, so your pharmacist can also be a partner. What do you mean she hasn't picked up her prescription yet? Well, let me call her. And then I'll call her sister, and I'll call her brother, and you'll call everybody else to get her in to fill a prescription. And then don't forget to ask the patient, what would help you take your medication as prescribed? You ask open-ended questions. You can even start questions like this. Tell me why you missed medication, or why did you miss your pill this month? Oh, that assumes already you know I missed it. Okay. You must have some kind of psychic power, because I didn't tell you that I missed it, but you know. Okay, now I'll give it up. So you ask questions that take some of the, folks really want to please us, and sometimes they'll lie to us to please us, and that doesn't really help them at all. But you have the patient identify, what do you think is going to help you take this medicine as prescribed? And then you say to their family, what do you think is going to help this person take this medicine as prescribed? If it's a once a day, you might have them put it by their toothbrush. People usually remember to brush their teeth. They may not floss, but they brush. And putting it somewhere that they might remember. With nilotinib, I always make sure that the patient thinks nil. And nil for me means no, so nil, watch out with foods. So you give them a little tags that help them remember things. Calling them frequently. There are a lot of medication reminder systems available. They'll beep, they'll whistle, they'll send you a page, they'll send you, do everything but come tap you on the arm, give you a glass of water, and tell you to take your pill. Everything short of that. But you want to make sure that you've got everybody on board. Things that you may not think about is there are a lot of folks who don't read and write. And often, by the time they get to the age where most of the people where we're treating, they're not going to tell us that very easily. They've been pretending for a long time. They might be really good at making people believe that they can read. And don't forget the health literacy part here. They can be very literate, but they can't sometimes know medical literacy. Do they believe this medicine is going to help them? First of all, do they believe that they have something that needs to be treated? Beck's assessment would always say that the patient has to believe in the therapy in order for it to work. Probably the most important is that practitioner-patient relationship. If you're giving that feeling that I really care about you and I want you to do the best that you can do and not being judgmental, that relationship is going to be very worthy as far as having a person be compliant. What else could be going on? Are they depressed? Maybe they don't have any support. Maybe they're taking their little lonely pill in their house all by themselves, and nobody really is there to help them or care whether they have taken that pill. Sometimes it is the money. Sometimes even the copay is way out of what they're able to pay. At my hospital, it's $3 to park. I can't tell you how often those folks don't have $3 to get out of the garage. Denial of illness is really important because if they don't believe that they need this treatment, they certainly are not going to be making money for it or providing room for it, and also following up with the things that you need to be compliant. So this terminology, compliance, that's old. Compliance is kind of paternalistic, and we're trying to get away from paternalism in medicine. Well, not really, but we're saying we are getting away from paternalism. Adherence is the new buzzword because it means that the person is adhering to the plan. They're going out, they're taking the prescription with them. They're going to the pharmacy, they're getting it filled, and they're taking the medication as much as they can. And that also means making sure that they're not having the grapefruit juice, and they're watching other medications, and they're telling us. The thing that happens with CML that's kind of worrisome is persistence. For the first 6 months, you'll get somebody who's pretty able to stay on track with treatment. They'll do the things that they need to do in order to turn their health around, in order to have a better chance at a long life. But persistence means that they need to continue to take that therapy even after it becomes boring. You know, in the first 6 months of a disease, oh, okay, I've got a big disease, and you're talking about it, and you're telling everyone about it, and everybody's, then it gets kind of boring. Oh, tired CML. So persistence is the ability to still stay adherent to recommendations after the big opening in the beginning where everybody's excited about it. And that's where we lose a lot of patients. There are a lot of research, and when I did the research for this, piles and piles and piles of papers that basically said there isn't one strategy. It's an individualized assessment, and then everything that you can do to help that person stay compliant is going to be helpful, because nothing works for every single person. Trying to find out what is it that I can do for you to help you be adherent, and then providing alternatives for that. It may be that you have 5 patients that you call every week. One patient you need to call once a month, and then one patient never answers your phone. So you might have to send them a postcard. There's not going to be one thing. Find something that works for your patients, and then move that along, and something will work for another patient, and you'll grow your ability to help folks stay on that treatment plan. So I'm going back to you.
I believe that's correct.
Very good. And I'll give you back to Molly. Very much. Go Steelers. You have extra for me.
Okay. Thank you. We all know that adherence and compliance and persistence and all of those things are difficult to manage in patients and to have them stay on track and stay on board. So some key takeaways from today. We'll jump to these in a quick second here, but if it's okay with you, we'll do a couple of quick questions that came up at the end of the previous part here. One of them was directed at me and the Sokol-Hasfield. Anyway, the question is, what is the significance of the Sokol and Hasford visit scores, and what do they actually indicate? Well, they are indicative, they sort of have a prognostic value in the likelihood that something that you may, the prospect of converting into an acute leukemia or going into blast crisis. And so they are important. What they are is they're formulas that weight different values. And that's what all of that 0.006 something, they help to weight different values so that you can calculate numbers and scores. And so looking at basophilia, the number of white blood cells, the number of blasts, your platelet count, things like that, all are indicative of how aggressive the disease is up front. So I hope that was helpful. And then we've got about, where's my time decatur? Who's my time decatur? What do I have left for time? How long do you think you can pay attention? I guess that's, we've got about 10 minutes. How long can you pay attention? Well, we're sorting through the questions up here really quick. I'll just tell you how I got my mom to be compliant, adherent, and persistent with her Coumadin. She couldn't remember to take it on a daily basis, and I said, Mom, what's something that you do on a daily basis? Brush your teeth? You want to put it by there? No, I hate that idea. I said, okay, do you still have a gin and tonic every night? She said, yes. I said, tape it to the gin bottle. She said, oh, I don't think so. I said, better yet, how long does it take you to go through a half gallon of gin? About a month. I said, crush them all up, dump them in the gin bottle. Every night you get the same dose. Mother was none too pleased.
Well, I did my fellowship in Michigan. I think I'm starting to understand Ohio State fans a little bit better now. So there's a lot of thoughtful questions here. I'd just like to kind of go through a couple of them quickly and then hand over the microphone. There's a question, if nilotinib has additional activity, i.e. SARC inhibition, is it more effective than dasatinib or imatinib? Dasatinib is the drug that has SARC inhibition, not nilotinib. And at this point, it's all theory whether or not that SARC inhibition actually leads to better survival, because in not a head-to-head study, but in separate studies versus imatinib, it has equal cytogenetic and molecular responses. The folks in Chapel Hill, go Heels, want to know what is the approximate percentage of BMT failure patients. So, and can these patients go back on a TKI? So it's an interesting question. So patients, it depends why they go to transplant. So patients who go to transplant because they are not adherent to a TKI still have a drug that's going to work for them. So if there's a way to make them adherent in the new age, post-transplant, then yes, there's a possibility to use the drug again. If there's a new drug that's out that doesn't cause the same side effect that they had. If there's a new drug like ponatinib, and they before had a T359 mutation, well, yes, ponatinib is now available in expanded access and hopefully approved by the FDA this year and will be available to be given to people post-transplant. As far as who fails transplant, CML is one of these diseases that's a great transplant. It's a transplanter's disease. I really took the meat out of transplantation when TKIs came along because we don't transplant those patients anymore. They rarely relapse. The problem is they still have the same rates of GVHD that everybody else does with allotransplant. Your experience with treating a patient with CML who had gastric bypass. Oy vey. I have had a couple of patients who have had gastric bypass in the past or have had it while they're on therapy. And I've been lucky enough to have maintained my responses. We'll see what happens. One of them I'm following actively. Yeah, you're worried about absorbing of the drug. And the best way to keep track of that is to actually check dasatinib, nilotinib, or imatinib levels. Those are not commercially available at Quest or US Diagnostics, but you can find labs to do that for you. And that would be my suggestion if there's a concern about reaching drug levels in those patients. If they're not reaching levels, you can increase the dose. And if it's an issue of getting insurance to pay for the drug, that's not an issue with imatinib going 800. It is an issue. You start increasing nilotinib or dasatinib. And I encourage you to engage those drug reps who are coming by your office and buying lunch. If you haven't run into this kind of problem, ask them to do the legwork for you, and they will. Bless you. Can I do one more? I like this one. So, Dr. Savona, I have an older patient in the 80s on Gleevec for 2 years who stopped for severe pancytopenia. Would you restart the Gleevec after recovery or change drug? Not necessarily either. I would bone marrow the patient because an 80-year-old patient is also in the demographic for myelodysplasia. And not only can patients in the 80s just develop myelodysplasia, and it's the most common hematologic malignancy, by the way, vastly underestimated by SEER data, because SEER data is from death certificates, and most doctors don't recognize MDS when the patient dies because they die of something else. As an MDS doctor, I feel a need to make a point of that. The other thing is that patients who have a bone marrow disease like CML to begin with, they're more likely to develop a second bone marrow disease than people who don't. So I think those people need a bone marrow biopsy, and the decision is based on the results of the bone marrow biopsy. Another great question from the same card, and I really want to answer this while most folks are still here. Dr. Savona, are the drugs continue for life if you stop after 1 year or more of normal leukemia lymphoma profile? Great question, and we're answering this with clinical trials. Nobody should go off drug right now outside of the context of a clinical trial. Please. And this is the danger of doing clinical trials, because what happens is a paper is published. The Stop Imatinib Now trial results are published, and 18% of patients in complete molecular remission were at a 4.5 molecular log reduction in their bcr-abl to ABL ratio after 3 years were stopped, and after 2 years they have no evidence of disease. So guess what happens when that gets put in the New York Times? Everyone comes into my office with the newspaper and says, I'm stopping my drug. Nothing you can do about it. And I have to spend the next hour convincing them of why they need to stay on the drug. There's going to be a time to do this, but the safe way to go off the drug is in the context of a clinical trial that ideally includes a drug that goes after that stem cell component, like that hedgehog inhibitor or a Wnt inhibitor or so forth.
Very good. So we'll wrap it up quick here for those of you who stayed. Thank you for having the strong bladders and fortitude to stay. So we need you to answer a couple of quick questions here. Now, which one of these is false? CML is characterized by chromosomal translocation. The Ensted trial studied nilotinib versus imatinib. The Saison trial studied dasatinib versus imatinib, or dose reductions or delays are not appropriate for grade 3 neutropenia.
The years start coming and they don't stop coming. Fed to the rules and I hit the ground running.
L, very good.
Very good. Yay! Don't hold it. Very good. Which of the following agents possesses an inhibitory property against the Sark family kinases? Is it imatinib, dasatinib, nilotinib? 1 and 2, 2 and 3, 1 and 3, all of the above? Still don't know. Yep. Very good, very good. See? You were paying attention. This is awesome. Good job. I'd like to thank my fellow panel persons.
I kind of remember that one by going, duh.
Duh. Yeah. And thank you to all of you for staying and coming to hang with us.